Okay, I'm going to present another case. We're going to move now into the recurrent space, and I'm interested in hearing your thoughts on this particular patient. So this is a 68-year-old Caucasian woman who was seen by her primary care physician for a recent onset of chest pain, shortness of breath, and she reported some recent vaginal bleeding and early satiety and a weight loss of 12 pounds. She has a past medical history that's significant for hypertension, arrhythmias, but both of which have been medically managed and stable. Family history is significant for cardiac history both on her mother's side, and her father had died of pancreatic cancer. She's morbidly obese. There's dullness percussion on the right, and she has a kind of asymmetrical chest expansion. And on pelvic exam, there's a mass or a suspicious mass in the pelvis. Laboratory findings are significant for a C125 of 445. Okay, and on imaging, she has a CT scan of the chest, which shows this effusion, which is confirming what we found in the on the chest exam. And her abdomen shows this 4-centimeter mass in the area of the left ovary with some residual mental caking and peritoneal implants. And there appears to be some involvement in the mesentery. So she has a thoracentesis, 1,500 cc's, and that cytology was positive for high-grade adenocarcinoma, and then ultimately has a pelvic mass biopsy with a core specimen that shows a high-grade serous carcinoma that has immunohistochemistry, which was nicely presented in some of the other cases that seem to be consistent with the P53, PAX8 positive, CK7 7 positive, CK20 negative. And in this patient, we have that has a germline mutation that's wild type for BRCA. So the patient has undergone some treatment before. So her treatment history consists of debulking primary surgery, which was incomplete. She had residual disease of 1.5 centimeters, and was given looks like the program of GOG-218 with paclitaxel, carboplatin, and bevacizumab, followed by bevacizumab maintenance to 15 months. And she achieved a complete clinical response to that. Then she undergoes a little over 2 years where she's disease-free, but comes back in with the symptoms that are very similar that we see in patients with recurrent disease. She has a severe abdominal bloating and fatigue, elevated CA125 of 255, and she has at least 3 sites of recurrence on imaging. And her performance status is 1. So she is given carboplatin docetaxel, and after 6 cycles of therapy, she has partial response, and her residual disease is at 1.5 centimeters. So this case has a lot of discussion items. I hope we can get through many of them. We want to talk about it, but before we get going too far, I want to talk about the potential molecular information we might want to gain. So we know that she is a germline BRCA wild type. Would you guys get any somatic testing at this point? Platinum-sensitive recurrent?
So
Dave?
we try to test up front where we do the somatic and the germline, as we talked about before. However, many of our patients, particularly within this time frame, would not have had somatic testing.
Right.
So if they had not had somatic testing, we would absolutely look at one of the commercially available and/or internal next generation sequencing of the tumor.
Is that the same?
Same thing. You know, we have in our institution, we have a clinical trial that we do next generation sequencing really up front. And so if we did not have that foundation medicine impact, anything of the sort, actually we would absolutely get somatic testing on her. Yeah.
Jim?
Yeah, same. I mean, previously we were really focusing on doing the somatic testing in the platinum resistant setting because we felt like that was really where you utilize that information. But now as we're moving these targeted therapies up earlier in the line, we're trying to do it as soon as possible.
Okay.